TopMedTalk.
All right. Well, hello and welcome to TopMedTalk. We are here in Seattle, Washington for the American Association of Nurse Anesthesiology 2023 Annual Congress. I'm Desiree Chappell, your host, and I'm joining you from the NorthStar Anesthesia exhibit booth here in the exhibit hall. It's a great buzz. Lots of vendors, lots of really cool booths, lots of great swag, actually, to see this year. So, we wanted to thank NorthStar for giving us this little niche, this little spot here to be able to record the podcast this year here at AANA. Now, if you're not familiar with the AANA, it's the official professional organization for CRNAs or nurse anesthetists here in the U.S., and it's the largest gathering of CRNAs in one place, student nurse anesthetists and nurse anesthesia programs. So as a CRNA myself, it's such a privilege to be here. It's exciting to see friends of old, make new friends, new colleagues, network around, which is great. So I'm joined by my co-host who is showing my swag around to some of the folks here, which is some good stuff. But anyway, Randy Moore, thank you so much for joining me and co-hosting. You are the Chief Anesthetist Officer of NorthStar Anesthesia, but you've held many roles here in the AANA. So thank you so much for sitting down with us.
It is a pleasure and honor to be your co-host.
Many people know you now as the NorthStar CAO, but you've held other roles, like I mentioned before. Can you just tell our listeners a little bit more about yourself?
I am a nurse anesthetist like you two. I actually haven't done a case in a while, so I should be careful about how I say that. You know, pretty early into my CRNA career, I developed an interest in leadership and management and moved into hospital leadership for a period of time in a few different roles. And then in parallel to that, I finished up my business education and then joined the AANA board of directors and served a few years in a couple different roles there. And then through a very interesting confluence of events, became the CEO of the organization. And I served in that role for 4 years, which was an honor and a privilege. And then it was time for me to move on and look for another adventure, and happened to have the opportunity to have a conversation with Adam Spiegel, who's our CEO, and the stars aligned.
Yeah.
And I moved over here into this role at NorthStar about 2 years ago as the Chief Anesthetist Officer, and having a great time.
Yeah. So our next guest is a fan fave. I say this every time, but one of our repeat guests here on TopMedTalk. We had a conversation at AANA last year with the incoming president-elect, Dru Riddle. Dru, thank you for coming back and talking to us again here at TopMedTalk.
Thanks for having me. It's exciting to be here.
Tell us just a little bit more about yourself.
I'm also a nurse anesthetist. My professional role in what I call my real job is as a faculty member at TCU in the School of Nurse Anesthesia. I've been there the last 12 years. And I am proud to say I'm in one of the original OG NorthStar CRNAs. I think I was in the first 10, 15, maybe 20 folks that NorthStar hired at their very first contract ever in Fort Worth, Texas. So,
yeah, it's still with us.
Yeah, it's been a great ride. Not to do too much of a plug for NorthStar, but they've been amazing to me and my family and my professional growth. And I owe a lot of where I find myself today because of the support I got at NorthStar, the culture, the people, the incredible patient care. I would go there, in fact, my own care. So that being said, I teach primarily practice, and then have served on the AANA board of directors for 3 years and entering my final year on the board as the board president in just a couple days.
Yeah, absolutely. Take the helm here in just a couple days. Really exciting. We just had a conversation with Angie Mund, who's our outgoing president, and Jan Setnor, who will be taking over your role as president-elect, and heard a lot about what happened last year. But, you know, from your perspective, how'd this last year go for you?
It was fantastic. Absolutely fantastic. As an organization, we have 60,000 or so members that are customers, but then we have the entirety of the populace that is served by nurse anesthetists that we also feel really responsible for ensuring that we're providing good quality anesthesia care, the provision of care, making sure we are prepared to go where we're needed to provide anesthesia. And so it's an interesting kind of dichotomy of, you know, there's a small governing body of the board of directors. There's an amazing staff. In credit to Randy and his time at AANA and really building up a bench of incredibly powerful professionals in the association management space. And then that just cascades down to all that we do kind of in the healthcare environment ecosystem. I think the last year went great. We had some challenges going into the year with some kind of right out of the gate issues with, I know we probably already talked about reimbursement parity and surprise billing and various insurers saying that we are no longer going to be paid what we used to be paid as nurse anesthetists personally providing or delivering anesthesia care. And we hit the ground running and I think made some really good progress there.
we kind of wanted to dive into that with you a little bit. We ended our conversation with Angie talking about reimbursement and the challenges with some of those changing models and workforce as well. In this coming year, what do you see? How are you guys going about tackling some of those things? And maybe we should start with breaking it down to talk about what some of the major issues are when we talk about reimbursement.
Sure. So the Affordable Care Act that was passed in the Obama administration had language in the statute that said payers, third-party payers, could not discriminate reimbursement based solely on the type of licensure. So whether you're a physician providing that care, an advanced practice nurse, a physician assistant, a chiropractor, et cetera, if it was within your scope of practice to provide that care, you should be reimbursed for that care at an equivalent level to others. And it is irrespective of your licensure. Unfortunately, there were no rules. It's sort of like I've explained this to people, as a parent, when you tell your kid, don't do something or else.
Yeah.
But you have no idea what the or else is. You're just hoping like they don't call your bluff on that, or I'm going to count to 3. Don't make me get to 3 because I don't know what I'm going to do when I get to 3. So we have sort of this mantra that came out in statute, but we had no rules to enforce it, which means that there's no opportunity for the government to step in and say, hey, this is actually not legal. This isn't something you can't do. And so we are working, unfortunately, because the federal government is as complex as it is. There's several different agencies that have jurisdiction because of the way this falls under federal statute. And we've been working diligently with each of these individual agencies to promulgate rules around the enforcement there. And what it means really is not, it sounds like, well, I need to be reimbursed. I need all this extra money. It really has to do with access to care for our patients. Patients that are receiving anesthesia care that is administered by a certified registered nurse anesthetist, that CRNA should be appropriately reimbursed for the professional services they provide, which is actually provided under federal law to do so. And if we are unable to be reimbursed or be reimbursed at an equitable level, then the ability for that nurse anesthetist to continue to provide that care comes into question. And it's the public, it's the U.S. citizens that end up suffering at the sharp end of the spear, if we want to think of it that way.
Yeah.
Did I explain it correctly?
Well, that's good. The interesting thing about all of this is, as we think about the challenges associated with reimbursement for CRNAs and other advanced practice nurses, and the headwinds actually are getting stronger in that space, right? So if you look at recently, and this is, it's for a very long time, state by state, commercial payers have said, hey, we've decided to pay CRNAs some percentage less than what we'd pay from the physician fee schedule. And there's been kind of a state-by-state battle with that, trying to persuade them that that's the wrong thing to do. Well, now, that is taking shape in a way that where Cigna, which is one of the largest commercial health insurance companies in the United States, has said, hey, well, actually, across the board, we're going to decrease CRNA reimbursement 15%. And I know that that's a very serious issue, not just for the AANA, but for CRNAs. And, oh, by the way, groups that employ CRNAs, right? And who may want to use QZ billing in a way to facilitate their practice models. Dru, how are you and the AANA thinking about this in terms of, this is another issue where, and look, this is the United States of America. Let's be real for a second. Healthcare is largely driven by money, and anesthesia practice models are often formulated based on how much revenue they generate. Yeah. So as we think about how things are playing out, how are you as a leader within the organization, and then how's the organization's strategy reflecting, where these headwinds are taking the CRNAs?
I think you framed it well, Randy. It's not, using air quotes here, not just a CRNA issue, but when there's a 15% reduction in reimbursement, whether that reimbursement's coming directly to me as a sole proprietor doing my own billing, or I work for NorthStar. NorthStar is receiving 15% less, 15 cents less on every dollar when I'm providing care under that model, when the patient for whom I'm providing care happens to walk in the door with Cigna. In anesthesia, unlike other specialties, we don't necessarily have the luxury of choosing our own patients. We're sort of present and ready to take care of every single person who walks in the door and needs emergency surgery, obstetrical care, pain management, et cetera. And so I don't really have the ability on the front end to say, oh, well, everyone except the following individuals are welcome here, right? We take all comers. So to answer your question, it is very much looks like to be a very CRNA centric issue, which I would challenge everyone to think differently. It is a entire healthcare ecosystem issue within the U.S. And so from a strategic perspective, from the AANA's perspective, we are partnering with other individuals that have a key iron in the fire, so to speak, around this issue. We can say all day long, oh, this is hurting CRNAs, this is hurting patients, but it does look a little bit very, very kind of centric and selfish in a way, because we are the professional voice for nurse anesthetists. But when other individuals that really are not in the business of advocating for a particular provider or type of provider say this is hurting our ability to care for patients and provide care. So part of that strategy is finding those strategic partners that are able to help us with that message. The second piece of that is understanding if there's opportunities for, how can I say this with being, there's opportunities to encourage Cigna and other third-party payers to sit down and have a conversation. And we're looking at some strategies that I can't go into specifically about how we mandate that to occur, because I'll be frank, and I'm going to call out Cigna. They have been 100% silent to every communication that has been sent to them on behalf of CRNAs by the AANA. There's been zero response.
Oh, I think that's interesting in this whole conversation is that I agree with you. Like, if I was a bystander and I was like, oh, too bad, highly compensated CRNAs and anesthesiologists are getting hurt financially, but oh, by the way, they're not. And the reason why they're not is because all of this, at the end of the day, is it's going to be resting on the shoulders of hospitals.
Yeah,
through increases in subsidies, right?
Absolutely, right.
And so that's part of the thing that's kind of frustrating, because in a world where there's a significant supply-demand imbalance of CRNAs and anesthesiologists, by the way, their salaries are not going to go down. So you can decrease the reimbursement all you want. It's just going to hurt hospitals and health systems who are
already in dire straits.
Who are already, their margins are already most of them, their margins are already in the red as we speak, and struggling.
And there might be some of the larger, perhaps more well-capitalized, more diversified health systems that perhaps, and this is out of my wheelhouse of expertise, but as I look at it, there might be a little more cushion in some of those systems. That the margin is razor thin regardless, but what we're actively seeing every day are small rural facilities closing their doors because they're unable to stay open. Financially, it is impossible to continue to provide high quality care because of a number of reasons. But having access to anesthesia care, it's beyond just, okay, well, I can get an anesthetic, but it allows me to offer services like emergency airway management in the middle of the night, obstetrical services, surgical services, pain management services, in many cases, intensive care unit consultation. And so the tentacles in which anesthesia kind of can reach, especially in some of these smaller facilities, with a 15% reduction in reimbursement, it becomes impossible to continue providing that care. And then at the end of the day, two big groups suffer, right? The providers and the employees of the hospital. And look, in some of these small towns, the hospital is one of the largest, that and the school system are the two largest employers in the entire community. So we lose one of the largest employers in the community, and everyone in that community loses access to high quality care. So it is, there is a little more than just the money piece. There are some altruistic aspects of this that I think we're just beginning to realize. Yeah.
The conversation is coming up, but, a lot of people are kind of sitting on their hands waiting to see what happens. And I'm a little bit nervous about that tactic. No Surprise Billing Act is something else. How has that really affected CRNAs in the CRNA community? Because we talked about that. I think we've sat back on and watching that happen. And
yeah, this can become a very political conversation very quickly. So trying to say more of how does this become operationalized? As I said before, we in anesthesia don't have what I would consider a brick and mortar office. Think about your family practice physician or your dentist's office where, there may be, and if you live in a large city, there may be a whole bunch of opportunities to go and find a healthcare provider. and in anesthesia, which means then the patients have a choice, but the provider has a bit of a choice as well. In anesthesia, we don't have that luxury. No one comes to the hospital for an anesthetic. Oh, and by the way, you're gonna have your knee replaced, right? I mean, that might be a market. There might be people that just want to come in and get anesthesia, but because we don't necessarily know or have any control over those individuals coming in the front door, but we absolutely are going to take care of them with the best high quality anesthesia care. I'm 2,000 miles from home right now, and if I show up to a hospital, I would be out of network. This is not the network in which my insurance exists, right?
Yeah.
And this idea of how do we take good care of those folks, but also recognizing that if I as a provider don't have a contractual relationship in that area or with that patient's provider, that somehow my reimbursement changes, gets different, gets decreased, it's a quagmire, and definitely affected the ability of some, especially again, some of the smaller facilities to stay open. I mean, there's really good things in that law that protect patients from non-transparency in healthcare, right? Yeah. And we all want healthcare to be more transparent, but there have been some financial implications to it for sure.
Yeah. And the net result, again, at the risk of belaboring my point, let me belabor my point, is, let's not lose any sleep or cry about, anesthesia clinicians or firms that employ anesthesia clinicians, because at the end of the day, again, surprise billing and the ability for commercial insurance carriers to have more leverage and to unilaterally and without warning decrease reimbursement for CRNAs and anesthesiologists results in hospitals and health systems taking it on the chin financially in the long run.
Yep.
In the short term, we've seen in our space, there have been companies who've struggled from a liquidity perspective, including one very large one who's right down the road there, who has declared Chapter 11 bankruptcy. So this has a real material impact on the anesthesia business, and for sure. But at the end of the day, it's the hospitals and health systems that are going to bear the brunt of this stuff. Can I could do a bit of pivot with
absolutely.
Dru, because Dru is on the front lines of producing future CRNAs. And that's a topic, believe it or not, that is near and dear to my heart. We've alluded to a couple times, the very real problem that we have about supply-demand imbalance for CRNAs and anesthesiologists. This conversation is talking about CRNAs. So as we think about workforce shortages, and as someone who's on the front lines of producing the future for the profession, and someone who also serves in a very influential role within the organization as the soon-to-be president, how's the AANA thinking about workforce shortages for CRNAs?
It comes up in every conversation, whether formally in a boardroom, informally over a cup of coffee. We talk about it outside of the AANA within our School of Nurse Anesthesia, because we're one of the larger programs in the country, and it's an absolutely huge problem. The threshold to become a CRNA, for folks that aren't familiar, you have to be a registered nurse. You have to be a registered nurse with specific critical care experience. You have to be really smart. You have to be really motivated. And then you have to have enough money to pay for school. And it's a 3-year program. And oh, by the way, while you're in the program, you're not going to be able to work. So you're going to have loss of income, right? Yeah. So there's a lot of headwinds against which we're working there. How we're thinking about it, there's a couple ways to go through this. So first is we have a problem recruiting and retaining high quality faculty.
Yes.
And there is a little bit of an issue when you have a whole bunch of people that want to learn, but no teacher to be in the classroom to help teach them. So we've actually been working with the White House and the administration on a regulatory side to free up and actually allocate funding specifically for supporting faculty development and allowing faculty to be able to grow and flourish and prosper in the academic setting. So we get enough teachers in the classroom, great. Then the next piece is we need to make sure we are advertising ourselves well to our very, very limited audience, because it's not like anyone walking down the street can sign up for our, weekend courses to become a CRNA. So working way, way upstream, high school and early college, to introduce individuals to the profession of nurse anesthesiology and encouraging them and mentoring them and building a pathway that works for them. The third piece has to do with the ability to offer high quality clinical training. We, unfortunately, unlike our physician colleagues, don't have federal funding to support, and they have GME money, graduate medical education money, where physician residency programs are funded, and actually those individuals are paid a salary. It's a penance, but it is some money to train to be physicians. Our anesthesia learners, our residents, are paying to learn because they're paying a tuition but have zero income there. So how do we work with Title VIII funding and graduate nursing education funding to potentially change that model a bit? But in the meantime, that takes a little while, right? In the meantime, I would encourage every listener who is an anesthesiologist, a nurse anesthetist, who has a practice in which you could offer the opportunity to train a nurse anesthetist learner in whatever facet is your area of expertise, get in touch with your local nurse anesthesia program. There's 132 programs or so in the U.S. right now. I guarantee there's one close enough to you. Give them a call and say, look, we could offer this and we'd love to have your folks come in. Yeah. So, from a workforce perspective, those are kind of the immediate, what can we do? I think there's probably a whole other couple hour conversation on why we got to where we are we could talk about. But anyway.
Yeah. Well, I'm so glad you went over that, Drew. I have not actually heard a lot of that. And so it's good as a constituent of, and a CRNA to know that the AANA is working on that. Now, that makes sense to me. Some of the other things that, we've talked about solutions may not have made as much sense, but I think that seems like a good direction. So, Drew, we got to wrap up. I know you're super, super busy. What are you most excited about this year?
I'm excited to see, I sat with you guys last year.
Yeah.
There was some change between last year and this year, and I'm really excited to see where we land at this point. Hopefully next year when we're all in San Diego and maybe have a sit down one more time. I'm very excited for some really cool initiatives that I can't share, but can tease enough to say within the next year, they're going to be rolled out in a way that I think potentially changes the face of our profession in a really positive, unique, innovative, profound way. So stay tuned.
So, absolutely. Well, we'll definitely check back in with you next year. Congratulations, I guess, in 2 days on taking office. And we wish you all the luck in the world. And cheers to you.
Yeah. Thank you. Appreciate being here. Thanks.
And thanks for listening to Top Med Talk. You can always find us on your favorite podcatcher, on social media, Twitter, LinkedIn, Facebook. We are there, and at TopMedTalk.com. Over 2,000 different podcasts, which we've actually interviewed Drew plenty of times and interviewed Randy Moore whenever he was with the AANA back in our it's in our closet somewhere right there, the interview.
Nobody puts Randy in a closet. Did I just refer to myself in third person?
Maybe.
And misquote a movie?
It's that time of day that we start doing that. All right. Thanks so much for listening to Top Med Tech. Cheers, everyone.
All right. Thank you.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.